Thanks to each of the speakers for such thought-provoking presentations. Let me start by inviting folks in the audience. If you do have questions, please go ahead and start queuing up at the mics. But I'm going to start with at least one or two questions for our discussion. And the first one is, each of you spoke about an intervention or a suite of interventions that are promising to address multiple social needs. Many of you also touched on the problem of scale with respect to those interventions. So the question is, if you had to point to one barrier within the category of an evidence gap or a policy gap or perhaps something else that affects implementation, how would you think about that? Shreya, do you want to start us off?
I think my answer would thread the needle actually between the research gap and the implementation gap, because the thing that we see, we're working with thousands of different organizations across the country, and what has made it challenging is that a lot of places have community health worker programs or SDOH programs that they think are working, but they're actually not. And that's because many of these programs are evaluated using pre-post studies, as we talked about earlier in the day. And that, as we all know, life goes in these ups and downs. And if you start with a group of high utilizers or people with high hemoglobin A1Cs and follow them over time and do nothing else at all, their outcomes will improve. That's regression to the mean. And we're enabling that, I think, by the way that we are talking about this work. And so recognizing that you need to have really strong programs requires knowing how your existing programs are working.
We don't necessarily have to go down the line, but Marcia, if you're willing, go ahead.
Yeah, I would just like to, absolutely agree with what you said. But there's also, and I mentioned this before, kind of multiple cultures, professional cultures going on. So for civil legal attorneys, it's anathema to think about not taking the next case that presents because they're in front of you. If the lawyer has the skills and the ability, the lawyer wants to address those needs. These are not highly compensated lawyers. These are people who are doing this for unbelievable commitment. And so to get lawyers to think about high needs in the same way that healthcare organizations are thinking about high needs is a difficult task, and it takes a lot of training. So to be able to get that information and to target and get data, you have to first decide what's the problem, defining the problem. And I think it's very different depending on who's looking at it.
If I could just give a brief metaphor, and my colleague Dana Weiner, who's a psychologist at Chapin Hall in Chicago, shared this idea with me. Apollo 13 had a crisis in outer space when an oxygen tank exploded. And for those of you who saw the movie, remember the story, there was a miracle when the astronauts were brought safely to Earth. NASA, when that tragedy happened, had to make a choice about whether to focus on what was broken or what was working. And they made the asset-based choice, what was working. And they reassembled this spacecraft to do the unthinkable, which was to bring these astronauts safely to space, from space. So the analogy here is they had an expert on the ground for every working part. We don't have that. We don't know every working part of our communities, and we're largely thinking of our communities, especially where our lowest income people live, as deficit places. They're deserts. They're broken. They're places people don't want to go. We could look at our communities as asset places. And we have to do the hard work to identify the assets because, as I mentioned before, 30 to 40% of what Google tells us is there is not actually there, or there's something else there. That's a hard problem to solve. I think it could be remedied with policy that says if you give philanthropic dollars to a community, to a nonprofit organization, or there are government tax dollars, there are certain standards of both infrastructure these organizations must have, like an internet connection, like technology that everyone else in the 21st century is using, and that every program and service these organizations are providing are worth nothing if they're not transparent to the public before they're being provided to anybody. So that, to me, is one policy remedy. And the related point is the internet infrastructure. Internet is a utility. It's no use to have a human services organization that has water and air conditioning, but no internet. And so we need to be concerned about differential access to internet, and I don't think we're going to solve a lot of these problems if we don't solve that. So I think to HHS, that would be one of my recommendations.
Thanks. I think, for years we've talked about solving the wrong pocket problem, and we're getting closer with all these value models. But I think, Chukar talked about having people for a long time, and that we're...
Sarah, do you mind the wrong pocket problem, just for people who may not be as familiar with it?
Of course. So if an investment in something saves money either much later or to a different institution, so for example, preschool may save money on prison population, but the preschool doesn't have that money that the prison's going to save on it later. Thank you. And so, for example, like Capable, where you're paying for working on the house and the nurse visits and OT visits, but it's Medicaid and Medicare that are going to save the money. How do you get Medicare and Medicaid to pay that money up front? I think we're starting to make that shift as we focus more on value. But I think there's real time horizon issues that we need to work out, and that the places like the VA, as was mentioned this morning, who know they're going to have people for a long time, are more comfortable making those investments than places that some insurance companies may treat people poorly, figuring, oh, we won't have them next year. And so solving the temporal aspects of the wrong pocket problem, I think, are important.
Great. Why don't we go to a question from the audience?
Thank you. My name's Lee Holland, and I'm with Pharmacy Quality Alliance. And I just want to say thank you for this great panel. I mean, just bringing out a lot of really great programs that sound like they're really helping patients a great deal. Recently, Pharmacy Quality Alliance, we just finished up a report on access to care where we were looking specifically at access to medications. And as we were going through it, much to our surprise, we found that there were a lot of non-medical barriers that patients were facing, and it was also really tied into the social determinants of health as well. One of the things that we looked at was health literacy, patient health literacy, and we included in that definition of health literacy a patient's ability to navigate the healthcare system, and that was a really big issue that I think, speaking of the legal medical program, I think that would really help a lot, and also issues with organizational health literacies, with healthcare organizations not knowing how to refer patients either within the healthcare system or outside to some of these social services that they need, that some of these programs you've put together have just so adeptly helped patients with. And my question is we're getting more and more knowledge, we're getting these programs. How do we come up with programs and policies nationwide that can help patients?
Open to anyone.
I think I could just say, as a principle, we have to work across sectors, and we need to engage the private sector. Walgreens was a company that wrote a letter of support for the Community RX proposal. Their view was that their pharmacists were the frontline health and the most trusted health providers in the communities we were serving. So I think that I would suggest the idea, and Mayor Emanuel uses this term, inclusive growth. As we grow healthcare from a sick care system to a well care system, we ought to think carefully about how we create opportunity across all sectors, especially those smaller community-based organizations that have been doing this work forever, to be part of the solution, not get pushed out of the solution. So that's a principle-based, not a specific answer to your question.
I would just add to that. I agree with everything that Stacey just said. And I want to even go beyond that and say, let's not forget about the people even underlying some of these community-based organizations. A lot of the conversation in the SDOH space is somewhat top-down. We think about giving money from the federal government to states, to localities, and if we're really aggressive, we're thinking about giving them to CBOs. But CBOs are made up of self-selected people that aren't the diabetic woman who lives under a bridge. How do you get to those people, both in terms of hearing what they want and also enabling them and recognizing them as assets in the community? I just use that in quotes because they're people. But and I think that's, for me, the power of the concept of community health workers, is that they are actual individuals who can help patients regardless of their need, whether it's health literacy or housing or food or whatever. And so I think there's tremendous efficiencies in that approach.
So I do some work for a specialty organization that is focusing on a certain disease, and recently did some patient surveys, and found that these are people with disabilities. They have a lot of problems getting access to care, and when they do have access to care, they have a lot of financial burden. So this notion of financial toxicity is growing. And my suggestion to a group of healthcare professionals at a meeting of theirs was to have physicians and nurses and others who are care teams ask about whether there are problems getting these things, whether there are financial problems, whether there are barriers getting them. And a physician in the group said to me he felt uncomfortable. He really felt uncomfortable asking patients about their financial situations. He thought it was disrespectful, or he just felt uncomfortable. And I said, as a patient, I said, you asked me to take my clothes off. You asked me if I take drugs. You asked me about sexual things. You can't ask me if I have the money to get my medications. So I think, it's a hard question to say what happens nationally, but I think if we recognize that people have trouble getting services, that they have trouble just even managing the basics of getting their pharmaceuticals, then there would be, greater awareness does help. And then, of course, all of the federal programs that are now recognizing and being more flexible about how they think about benefits and adding certain non-clinical things to the benefit. But I do think attitude is important, too, about just going the extra step and saying, are you going to have any trouble filling that prescription?
So allow me to follow up on this a bit, because your comments are all touching on payment policy, as a way to get to national level scale. So let's talk about that a little bit more from the perspective of, the idea that value-based payment is often invoked as something that will help move forward investment in interventions that address social needs. Maybe tell us a little bit about whether or not you feel bullish on that idea, and if not, if you're a skeptic of that, then how would you change what's happening with value-based payment to make it more reflective of what you're trying to advance?
I feel very optimistic. Might just be my personality, but the growth of Capable is now in 27 places. 25 of those came out before our randomized control trial did, which thank goodness had the exact same results as our earlier studies. But it was an indication of the need. There's just huge need for what to do with low-income older adults who have functional decline, and no one's addressing it. And also, I think the hunger to do new things and to address this population, and that now that Medicare Advantage has the capability to add something like Capable, and we're going to be in front of the PTAC Commission, which is the commission that can tell traditional Medicare, tell Secretary Azar a recommendation for traditional Medicare, what it could add, and then just all the value-based payments models like accountable care organizations. I think Medicaid waivers, every state Medicaid program, on average, they take about 20% of a state's budget, and that's only going to increase. And with having the nursing homes being entitlement means that Medicaid really is incentivized to keep people as functional as possible at home. And so there's a lot of room in there. Of course, that's a state-by-state strategy, but I'm optimistic.
Yeah, briefly, I believe that economic incentives work. So for the first time in my too many years to count career as a practicing physician, we're regularly talking about how we keep people healthy. I'm an obstetrician gynecologist. We used to worry that if we didn't see enough low-income women, our NICU wouldn't be full. I can remember the day when I was lost. My innocence was lost in terms of what healthcare was about. So I do believe that value-based payment is shifting us from sick to health, and that's what we need in order to take care of whole people. NowPal's had a similar experience. We're in 9 states and 35 health systems, and those calls were coming before even the implementation study was published. The other policy I'll point to has to do with EMR adoption. Do you know what drove us to go from a paper and pencil industry, which doctors liked because you could scribble your handwriting and no one could hold you accountable, it took a safety concern about drug prescribing. We went from paper and pencil to digital, one of the biggest economic sectors, in just a matter of a few years. The human and social services sector are still paper and pencil sectors. So I think we need an equivalent policy, maybe, Karen and I started talking about this, maybe a meaningful use type strategy where there are carrots and then sticks that get the rest of these critical sectors online. But they also can't be deprived of the resources they need and the internet connections they need to become transparent parts of our health system.
I guess I'll just add that I think value-based payments set the table, but somebody needs to serve the meal and make sure it's a good meal.
Great. Let's go to another question from the audience.
Piggybacking off of those comments around the meals, Meetha Goyal from Northwestern University in Chicago, and also with the National Collaborative on Educating for Addressing Social Determinants of Health. As I listen to your programs, many of them are sort of infrastructures that are being created, and the entry point is usually going to be a clinical encounter, not necessarily, but perhaps often. How are you involved in preparing the healthcare workforce for being able to activate or to be able to recognize when this is happening in a systematic fashion, to be empowered to actually link to the services that you're offering and be educated enough and in order to make the correct linkages?
So a big part of medical legal partnership is the training part, where lawyers come in and talk to staff and residents and all kinds of people in hospitals and health centers about the importance of screening, recognizing when something is a social need could be resolved through legal services. But I want to call out Cincinnati Children's again, just for one point. They have an excellent residency training program there. So all of their pediatric residents are trained in their MLP. They work actively with lawyers. And so what's happening is you are now training a whole cadre of pediatricians to go out and be much more aware of these kinds of issues.
I think there's two ways I'd answer that question. First, I always say that impact was designed for dysfunction. What I mean by that is that ideally it works in ideal environments, but also dysfunctional ones where nobody is trained and nobody's making the referrals. And so community health workers are sort of, patients are enrolled in the program just on the basis of their characteristics, whether or not a clinician refers the patient. We prioritize referrals, but there's an auto-enrollment. Beyond that, we do have training programs for health professionals that we've developed and scaled across the country. Community health workers essentially are preceptors to medical students, nursing students, and they are apprenticed as community health workers for 2 to 4 weeks to learn essentially how to recognize the social determinants of health.
I'll say that our approach has been to put it in the water, to put it in the workflow. When we did the experiment for CMMI, the Healthy RXs, that's what we call the referral lists, were auto-generated using data that were already collected in the routine workflow about the patients. We know age and gender and home address and conditions, et cetera. There was no additional screening. I do believe that, first of all, we all do this work all the time. Just like we knew how to write prescriptions before there was e-prescribing, we always identify people's unmet needs. And those of us who are caring healthcare professionals, we surface these needs in every encounter. We've just had the worst, lowest quality, most disrespectful, unreliable processes for acting on those problems. And we feel terrible about it every single time. So I believe at scale, you just got to put it in the water. You got to put it in the workflow. Do some patients need higher intensity intervention, tracked referrals, coordinated referrals across multiple partnering organizations? Yes, some people would benefit from that, and a community health worker to steward them through the process. But other people just need the information, and they can act on it. And so that's been our approach to scale.
And I'll just quickly mention part of the secret sauce of Capable is motivational interviewing, which is not so secret, but that as healthcare providers, we often assume our patients are empty vessels that we fill with knowledge. And that really, motivational interview really flips that on its head. And that's part of the training in Capable is how to elicit goals, how to elicit what someone wants, how to build on their strengths and their assets. And so just to address your specific question, the training for healthcare providers for Capable has been kind of clunky, but in the next few months, it will have been done where there's simulations and it's all online, so it could be scaled much more rapidly to all kinds of healthcare providers.
Next question, please.
I have a comment which will line up more with the previous conversation and has come through the thread a bit today in terms of what is the recommendation on the national level. And I hear, I'm a physician, sorry, I didn't start with my name, I spoke before. Uche Uchendu is my name, I'm a physician in internal medicine, and I'm with Health Management Associates. But what bothers me is it looks like while we're very glad to see the value-based payment begin to draw in the social needs as requirements, looks like we're hedging a lot on that bet. That's not to say it's not going to work. I'm looking forward to seeing it work. But also, we're holding a limited number of people accountable. I tried to mention that in my earlier question in terms of holding other sectors accountable as well in a way that makes sense. While value-based payment is bringing it to the healthcare system, some of the earlier slides and other publications show that what the healthcare system can do is limited. While the healthcare system can light the candle or make the connection, there's a lot that depends on a whole lot of other people. So the question is, how do we diffuse the accountability to touch the necessary people, including a bridge? I still haven't heard a lot today about a bridge that connects the healthcare system and these lovely services that we've been hearing about and the passion and everything in there. How do we make that bridge very clear so that it's easy to do the handoff? You mentioned on the legal issue, doctors who may not feel comfortable asking somebody about their finances. But the other question that comes up is, should the doctor be the one asking that question? Among the healthcare team, if everyone's practicing at the top of their certification, maybe that's not a question the doctor should be asking. So how do we make that connection? Who are the appropriate people to make the linkage so that it's seamless on all sides? Because if the people are uncomfortable to ask the question, then you're not going to get the questions asked right. So I come back to the bridge and the accountability, and how does that get built in nationally as well, so that it's not just doctors who are angling for their pay from the value-based payment or the healthcare systems or the health plans, but that everyone else who touches the equation owns a piece of the accountability.
Well, all of you, I would say, have interventions that serve as bridges in some way. But to the question here, how do we make it so that the accountability for both the outcomes as well as the value, when we're talking about value-based care, are felt not just by the medical care system, but more broadly? So how would you answer that?
So I think that the future of SDOH, as I tweeted earlier, has 4 components. One is a hub. The Pathways model comes to mind for those of you know the work of Mark and Sarah Redding, some sort of a governance entity that brings together all of the health, social service, community-based governmental organizations within a given population or geography, sets outcomes, thinks about how data is shared, and governs how funding is distributed. So that's one, and that gets to the accountability piece. 2 is a handheld app that's used by patients/CHWs to screen and refer to both social resources, behavioral tools like gamification, et cetera. 3 are prediction models that allow us to identify the right individuals who need the right types of care. And then 4 are community health workers who actually do things with people like urban gardening and battling eviction notices. And their data in their routine care work can be plugged back into the hub and inform the targeted macro investments that we've spent the morning talking about. So I don't know if that's an exact answer, but the first part I think gets to.
No, definitely. Your program is taking those elements into account. What I'm getting at is what's at the national level, the recommendation of what should happen so that across the board, that ripple is felt and people own pieces of that action.
Other thoughts?
Well, I would say I saw Don Alley, and we have another person from CMMI working on the accountable health communities model. So I think that model is very relevant to your question. The work that NowPow is doing, and now I think 8 other companies are fiercely competing to do this, to be the bridge organization that enables at least the digital daily communications between all sectors in the caring community in order to enable people access to these enabling resources that maintain health. That's happening. There are solutions out there. Many of them would aspire to say that their solution does exactly what you just described. Most of them don't have a community health worker component. When I thought about the intervention we've created, even when we write about it to NIH in our proposals, we describe it as an adjunct to other interventions that are more intensive, more human-based, all of which are trying to connect people to resources, but do it with a piece of paper that somebody printed at the beginning of the trial and then never updated until the thing was over. So that's the kind of bridging I think we're seeing, and I would love to hear from the CMMI people about how AHC is going.
Okay.
Thank you.
Thank you. Allow me to get a little bit more provocative with a question here, which is, when we talk about people who have multiple social needs, probably the place to start with is why. And many of you touched on this with the stories that you shared, and it clearly motivates your work. But a piece of the conversation that we haven't explored too much is the idea that a big part of that why has to do with more systemic, structural issues. We live in a time of growing income inequality. There are challenges, particularly for patients who are immigrants in our countries. So the question is, are those more structural or policy issues beyond the scope of what we should be thinking about when we think about interventions to address multiple social needs? And if not, how do we do that without feeling paralyzed by how challenging that movement is?
I'll just start since I didn't say anything before. I really think it takes a village, and that there's so much work to be done, and we all have to do it where it works for us. When I was younger, I really wanted to do prison reform, and then when I got a little older, I really wanted to do public education reform, and both of those seemed like they weren't going to happen in my lifetime. So I chose healthcare, and but it just you have to pick what fits with your personality and yours. But we absolutely should be working on the structural.
Some would call you an optimist, actually, for making that.
That we have to work on the structural as well, but not each person can do each one, I guess I would say.
Well, for the last question, when we were, I was just stumped at what to say because I was thinking exactly this issue. So, how much can the health sector do? Just from the medical legal partnership perspective, the most common need that people present with that has to do with legal problems is housing, some form of housing. So, investments in housing stock, in community, I mean, you can go in any direction, would do wonders for the pressures on the healthcare system. And the pressures, and the healthcare system essentially is trying to catch up or fill holes. And someone said, is this the doctor's responsibility? I've often wondered, is it the hospital's responsibility to care about when the person leaves the grounds of the hospital? Is that the hospital's responsibility? Is it the doctor's responsibility? It's not clear whose responsibility is, except that it should be our country's responsibility on some level. And is it the most efficient way to do this through healthcare? Well, there's funding through healthcare, and there's a reason to say, if you're going to invest so much in caring for somebody in a clinical setting, it is penny wise and pound foolish not to take it and look at their whole person experience. It is just counterproductive. And I think that's why we keep thinking of these ways in healthcare, but it is not necessarily the most logical place to begin.
I'm just going to pick up on something John Auerbach said earlier in the day, which was helping us understand, first of all, the vocabulary, the words, which I think are very important, and we have something of a marketing problem, I think, still in this field. but how midstream and upstream ways of thinking complement each other. I want to just operationalize that. If we make transparent by bringing the human and social services sectors into the 21st century economy, if we make transparent their full inventories of programs and services and who they serve and when, and even the quality of those services, and if we can digitally connect clinical workflows to these community-based workflows, in the midstream work, we create a digital evidence of transactions, digital evidence of demand for these programs and services, whether they meet legal needs or other basic needs or chronic care management needs or caregiving needs. Every one of those needs would be digitally captured, which means it's real, because if it's not digital anymore, it's not real. And enough of those transactions start to give us, and actually very quickly, in a place like Kaiser, in 2 months, you can see the geospatial distribution of demand for these programs and services in the community across every single sector, the whole person approach. And you can see supply, you can see gaps, you start to learn who's doing what well, who has long waiting lists, who doesn't. Those data become the data that we can then use to advocate for the upstream, the social determinants of health problems. And who's in a good position to advocate? Those powerful CEOs we keep talking about. They're hugely powerful, but they are right now, we are all flying blind. We are lacking convincing data about the distribution of supply and demand. So until we digitize this problem, and that is not the panacea by any means. I love to lay hands on. I see my patients every week. I really believe in what Shreya is saying. We need the warm touch. But if we don't bring those other sectors into the 21st century, we will not make progress.
Dave, I'm not sure if this is what you're getting at, but why do these problems exist? Racism, classism, fundamental differences in power. And so how do we correct them? Susan Rifkin is a historian of community participation programs. I think she's at Hopkins. And she describes the two different frames for these sort of community participation programs. One is an empowerment frame, and it's about thinking of community health workers and these types of programs as a way to give power to normal, everyday people and away from the elite. And that's the empowerment frame. The other is a target-based frame, and it's about essentially using community health workers to meet health system targets for, lowering hospitalizations or getting people vaccinated. And so I think, that really applies to this larger discussion. Are we just trying to get people to Piggly Wiggly, or are we really trying to redistribute power and resources?
Yeah, I really like that. And you mentioned power. One thing that just triggers for me, something that many of you may have heard of, Marshall Gans talks about knowledge problems and power problems, and the importance of, in taking on work like this, not to confuse the two. There are some things that can be solved through knowledge, dissemination of knowledge and building of knowledge, and other things that require those changes in power structures. So speaking of John Auerbach, let's go to John for our next question.
Well, thank you very much. It's a great panel. One question I had, and maybe this is a research question or a policy question, is in order to, with each of you, to get the kind of services or programs you're offering up to scale, to go across state lines, do you think that there are barriers to that, or are there things that would be necessary in terms of maybe certification or standardized trainings or a certified model? I think sometimes Medicaid programs are risk adverse if there's not a sort of a product that has been certified by someone else, for instance, as meeting certain standards, or that they're sure that something has been tested that they can feel comfortable has results. So the question is would a policy, is that an obstacle? And if it is, would policy or research be helpful in terms of moving that ahead?
I think all of us probably have certification and training for what we're talking about, and I think the trick is to make it as easy to use it with fidelity, to use these programs with fidelity. Kate Lorig who had the chronic disease self-management program, she figured that out a long time before the internet, and it's all over. But I think that the more we can make them so that they can be done in your pajamas at midnight. It's a kind of certification with some high touch as needed. And I think absolutely places will need certification unless we get so far down the value-based road that nobody wants to take something up unless they're sure it's the real thing because of their own, that they want the money to flow in the right direction for theirs.
Well, just thinking about some of these interventions, and I'm obviously thinking about the legal one, it's kind of constructed as a retail model right now. And there needs to be a very big shift in thinking to take this to scale, to take this to be an intervention that would be available nationally. So the VA is really interested in MLP, especially for veterans who have housing issues. There could be telehealth or telelegal. Montana's doing that to try to share lawyers and do consulting. But the notion of I love MLP, but the notion of bringing a lawyer to a bedside is inherently limiting. And so there's a model called Dulce that has been promoted and tested in RCT and now is being spread to, I guess, about 8 sites. It started in California. And it's for it's from birth to 18 months, something like that. And it's been shown to be very effective. And the lawyer is really counseling family specialists, so that the staff, not direct to patient, but direct to the staff, to really train them. And very little kind of one-on-one counseling. So to bring that more to scale, and that has some opportunities. But I agree. Going local to community has its strengths. It also has its problems for scale.
In the realm I'm working, which is how to identify community resources and match people to them to address the full range of whole person needs, we haven't encountered statutory barriers, so to speak. A dynamic I see is that state Medicaid offices are wanting to adopt systems to tightly manage, track, coordinate care for high utilizers in Medicaid. Which is probably, it's an analogous solution, but it's different than really deep, hyper-local knowledge about the programs and services and who gets what. And the two things are probably compatible. I think one thing I worry about is if we make SDOH all about high utilizers, we forget that high utilizers were not high utilizers their whole life. People become high utilizers, as the point was made earlier, because we have not intervened soon enough, or because of the structural, true social determinants of health problems that we have. So I think one of the things I'm seeing it from the market side of this is that some vendors with these solutions are really going after the state Medicaid customers. Some vendors are really focused hyper-local on health systems and community-based organizations, and some are, somewhere in between. And I think it's probably that there's room for multiple solutions.
Great. Next question, please.
Hi, Dave Liss again from Northwestern. I want to start by saying thanks to the panel. Really enjoying this chat. In this discussion of scale and some of the ways that you are expanding and sort of exporting your interventions to communities throughout the U.S., looking at people doing this work that at least started in Philadelphia and Washington, D.C., and Chicago and Baltimore, I wonder if you could talk a little bit about expansion and scaling to maybe more rural areas or even smaller metro areas, and some of the things that have worked well and some of the things that maybe have not worked well that you're some of those barriers you're encountering.
Sure. I think the short answer is that it works well in rural areas, and I think you have to design for scale even before the implementation phase and certainly before the scale phase. So I think we were pretty deliberate to make impact a universal, adaptable model with just fundamental principles that can operate in a lot of different environments.
So with MLP, it's highly customized. You have a group of lawyers who say, I think I'd really like to talk to the health center down the road. That doesn't happen as much in rural communities because there's not as much capacity in rural communities. So it's something that we're trying to work with primary care associations and other groups to stretch those kinds of resources.
You give me the opportunity to describe a project we worked on together, Healthy Hearts in the Heartland effort, which was supported by part of the AHRQ Evidence Now initiative. So we were focused on small primary care practices, some FQHCs in the Midwest. It was a much bigger trial, but one component of the trial was to attempt to give small primary care practices a tool that would enable them to connect patients to community-based resources that would prevent cardiovascular disease, primary and secondary prevention. We found it very difficult, and the main barrier was actually the capacity at the practices to enable digital integration of technology. They needed to go with a hard copy piece of paper that listed resources nearby the clinic that people could use to support their health. We learned a tremendous amount, and actually, we're all coming from more of the academic, large health system point of view. I think we do need to bring primary care practitioners to the conversation, because ultimately that's where the rubber meets the road in urban and rural communities. And again, inclusive growth of addressing whole people health needs to include those practices.
I'll just add that I think all of us do very whole person. That's why we're on the panel together. And when you do that, you don't need too many adaptations. Wherever you are, people are people. And if you're listening to what they're telling you, it's the same interaction. I think drive time is a bigger. And for older adults, you may or may not know this, but if you live long enough that you can't drive, you're still likely to live another 7 to 10 years. And so being in a rural area or a suburban area is tough for that. So there's all the more reason to provide these services in rural areas.
Great. Let me take the prerogative of the last question for our panel, and I'll acknowledge it's not a fair question given all of the nuances that we've just discussed. But I would love to hear you distill down, the one takeaway that you hope the audience members, and particularly with an eye toward the conversation that the Assistant Secretary for Health started this morning. What is it that you hope we would take away with respect to what is needed for us to move forward interventions to address multiple social needs? Maybe Sarah, we'll start with you.
This might count as two, but that physical function is important and modifiable, and that we should get at it by asking people themselves what they would like to be able to do. Maybe three.
I would say that we need to elevate our attention to detail around the vital assets of our communities to the same level that we treat drugs, because community drives health, drugs don't.
Okay, this is fun. I would say law is a social determinant of health. And so adding legal competence to a healthcare team can sometimes unlock amazing benefits for patients.
I feel like we're tweeting. I believe in science is what I would say. I think that, Stacy pointed out that we're humanitarians trying to make this look like it's science. And with all due respect, I think I'm a scientist, actually. I believe in truth, and I believe in using science to first channel the voices of people who are often not heard, and then use that to inform design of interventions that should be tested the same way that we test drugs and medical devices, and then use implementation science to scale it.
Great. What a wonderful panel. Please join me in thanking them.
All ladies.